All right, good afternoon, everyone, and thank you for joining us for today's discussion on donor-derived infections. My name is Deanna Fenton, Program Manager here at the Alliance, and I'll be joined today by our presenter, Dr. Michael Ison, who will review the current requirements for living and deceased donor screenings and opportunities to improve utilization of infected donors. Now, we're eager to go ahead and get started with today's conversation, but before we do, please allow me to share some relevant details with you all about today's program. Now, upon joining us today, you may have noticed that your audio lines have been muted. Please note that your lines will remain muted for the duration of the discussion. That said, all questions or comments will need to be submitted electronically using the Zoom chat feature. For those of you who may be new to the platform, please note that that feature is located at the very bottom of your screen in the Zoom navigation bar. Now, for those of you who submitted questions during the registration process, please know that we've done our best to compile your questions and we'll have our presenter address them throughout the course of today's discussion. Now, should you have any additional questions, please feel free to submit them using that Zoom chat feature. Now, for those of you who may be curious about continuing education credits, please note that there will be no credits offered for today's program. Having said that, you will still have an opportunity to provide us with your valuable feedback through our post-event evaluation. Following the conclusion of today's conversation, you will receive an email from us with outlined instructions on how to access the online evaluation. We highly recommend that you complete these evaluations as your feedback is invaluable to us and will help us develop future programs. If you have any issues or questions, please don't hesitate to contact a member from the Alliance team. Now, as an added note, we will be recording today's discussion. So if you or a colleague is interested in viewing the conversation at a later date, you can always access the on-demand recording on our website at organdonationalliance.org. There, you'll also find information about our upcoming programs and will, of course, have the opportunity to register for any programs of interest. Now, without further ado, I'd like to go ahead and kick off today's discussion by introducing our moderator. We'll be joined today by Katie McKee, who serves as the support of aftercare and hospital development at LifeSource. Katie, as always, it's a pleasure to have you with us. And at this point, I'll go ahead and turn it over to you to take it away.
Thank you so much, Deanna. And it is my honor to introduce today's esteemed speaker and such a relevant, timely, and exciting topic. Dr. Michael Ison is the chair, the first chair of the OPTN UNOS Disease Transmission Advisory Committee. He is currently a professor in the divisions of infectious diseases and transplantation at Northwestern University Feinberg School of Medicine. He is the director of transplant infectious diseases at Northwestern and the director for the Center for Clinical Research at Northwestern's Clinical and Translational Sciences Institute. He is also the editor-in-chief of the Transplant Infectious Disease Journal. And with that humble introduction, it is no surprise that he is an incredibly amazing speaker for today's topic. And with that, I am honored to turn it over to you, Dr. Ison.
Great, thanks, Katie. So today, what we'll do in the next about half hour before we open it up for some discussion and questions is talk about donor-derived infections and the promise of organ donation. And I really do think a lot of the work that has gone on over the last 12 years since DTAC has been in existence, and there's been a focus on donor-derived infections. We've learned a lot, and that has actually enabled us to improve organ utilization. We got rid of the HTLV testing requirement, which resulted in a significant reduction in organs wasted, having probably somewhere in the neighborhood of 250 to 300 organs available every single year. The effort to require nucleic acid-based testing allowed us to understand those patients that are at lower risk, again, probably adding somewhere in the neighborhood of 200 to 300 extra organs to be utilized every year, and allowed us to understand the ability to do things like use Hep C infected donors into uninfected patients, and broaden the use of HIV infected donors for HIV infected individuals. So here are my disclosures. And what we'll do is we'll start by some definitions, understanding the risk and understand risk mitigations, and then finish in the end about opportunities to expand the donor pool. So by definition, a donor-derived infection is any infection in the recipient that results in an infection in the donor and is transmitted by the donated organ. This happens every single day. We do this in an expected way for things like hepatitis C, EBV, CMV, and even toxoplasmosis, where we know that the donor has an infection. We use those organs from the infected donor, and then we either monitor the patient or give them prophylaxis to prevent the infection from causing disease. But where we'll focus on for the majority of our discussion today are those unexpected risks. This is where we don't recognize that the donor has an infection, but it's inadvertently transmitted to the recipient, and that's when we discover the infection was present. This happens very infrequently, about 0.15% of the time, is more common among deceased organ donors than live donors, but as we'll talk about, even living donors aren't immune. So let's first start about thinking about the problem. And really, this is a case that really highlights the need for the work that we've done. This gentleman was a 54-year-old gentleman who had HBV, HCV, and hepatocellular carcinoma, underwent an uneventful lung transplant, and then 5 days after the transplant, developed a fever with mild frontal headache. You can see his immunosuppression and antibiotics. He lived in suburban Boston and was an iron worker, and really had a non-focal exam to suggest where the fever was coming from. He continued to have fevers with worsening liver function tests, had a seizure, and had progressive sepsis of unclear etiology with worsening liver and kidney dysfunction. We then got a call from a transplant infectious disease doctor at a different hospital to let us know that the 2 kidneys she was taking care of had the same clinical syndrome, and that the lung patient had died from with a similar syndrome the day before. Through an investigation led by the CDC, we found that the donor had bought her son a hamster. That hamster likely had, or actually was proven to have a virus called LCMV. This typically causes aseptic meningitis and really doesn't cause much harm to most otherwise healthy individuals. Unfortunately, the donor had acquired this infection, which didn't cause her death, but was transmitted on to the recipients. This case, though, highlighted the need for the collection and coordination of cases such as these, because when we went to write up the case, we thought we had the first, when in fact, the CDC had said that they had at least one other case that had already been investigated and several others that they were in the process of investigating. And so that led to the development of OPTN policy, what was called 4.7 back in the day, 2009. Now policy 15, that requires any transplant program to, as soon as they recognize or see that a recipient has an infection or transmissible disease that they think may be coming from the donor, they have to report that immediately to the OPO. And by immediately, they mean as quickly as possible, but no greater than 24 hours after recognizing this. The OPO then, through the work of the OPTN, coordinates discussions and data collection from the transplant centers and tissue banks, helps to manage the investigation, and submits a final report to the OPTN. Eventually, this was codified in policy, and then a working group was put together as a part of the operations committee at UNOS. I've listed the initial members, relatively small group, and we had our first case reported, which was a probable transmission of leukemia. What that taught us is that while this was designed to identify and manage infections, it was going to do far more than that, and that we needed to build our expertise beyond just infectious diseases. Shortly thereafter, I became chair of the working group when it was formalized. The first reportable infection came through, a case of Legionella. This also taught us an important lesson that we are going to have to interface with public health very closely with this effort, because many of the pathogens that we see are reportable cases. We also, as we started this, we really were starting from scratch. No one in the world had created such a program, so we were building the project as we grew. What started with the paper project really formalized into a much more sophisticated electronic system, as I'll talk about in a few minutes. One of the first cases that really got the focus on increased risk donors and donor-derived infections occurred with a patient that we had at our center. He underwent successful kidney transplant, which was his second. He was highly sensitized and was consented to receive the increased risk donor. About 3 months post-transplant, he had elevated LFTs and had negative serology for hepatitis, but then biopsy showed changes consistent with hepatitis C, and hep C PCR was done, showing greater than 10 million copies. 10 months after the transplant, he had renal dysfunction, and a biopsy showed BAMF1A acute cellular rejection, but also significant changes consistent with HIV-associated nephropathy. He had a positive HIV antibody test and a viral load of 520 copies per ml. He was referred to ID for evaluation. We actually saw him when he was admitted because of a diarrheal episode, and that kicked off the investigation. Unfortunately, in this case, all 4 recipients of the same donor acquired both HIV and hepatitis C from this donor. And it highlighted the importance of doing PCR testing in the recipients, since none of the recipients had a positive hepatitis C antibody test, and HIV testing gave indeterminate results in one of the 4 recipients. As a result of this transmission, the community quickly responded, requiring an informed consent. They revised the policy at OPTN to require stringent evaluation and management of these patients, and there were calls for updates to the PHS Guidelines. This also resulted in a change of DTAG into DTAC, where we formalized the structure and were broken out as a standalone committee. We partnered with a number of groups, including AOPO, the Israel Penn Transplant Tumor Registry, the Living Donor Committee, and the CDC, to really develop processes and structures that would really work effectively for the community. We also developed a standardized approach to classify these cases, anywhere from proven, where we could prove the same pathogen or disease in the donor and at least one recipient, to various shades of gray down to excluded, where we could say that the transmitted disease was not present in the donor. Over time, we saw a significant number of cases. The number of proven and probable cases, those that are true transmissions, increased initially, but then has stabilized out at around 40 to 50 cases per year. The majority of the cases are malignancies, with only about 12% having confirmed transmission, but still having the highest mortality when transmission occurs. This is followed by a range of viruses, bacteria and fungi and mycobacteria, as well as parasites, with variable degree of disease transmission confirmed in the donors, as well as variable mortality. The highest mortality are with parasitic infections and mycobacterial infections, in part because they oftentimes are not caught early and relatively late. Bacterial transmissions probably occur far more frequently than we recognize, but many times I think many clinicians may not think that it may have come from the donor and look back and review their overall cultures. Dan Call, the third DTAC chair, just published the data from the first 10 years of DTAC's existence. And really this kind of helped us better understand when many of these pathogens are recognized. The majority of transmitted diseases are recognized within the first 30 days, although some may present a little bit later. And again, these tend to be those parasitic infections, things like TB, and other pathogens that may take more than a month to incubate in the patient before they cause specific illness. Over the years, we've also validated the fact that efficient and fast communication of these cases is associated with improved outcomes. And this is why there's a huge effort to enforce the policy, which is that the reports need to come in within 24 hours. And again, this is important because, as we found, those patients that had efficient communication had far fewer transmissions and adverse events than in those patients where there were communication gaps and delays in information. So you had nearly a doubling in the risk of transmissions and fatal outcomes in those cases. So again, rapid communication really is the key. Now, as we all recognize, and this is a slightly outdated graphic, but essentially is still holding true today, the number of people waiting for transplants far outstrips the number of individuals that end up getting transplants because limited organ availability. Each year, about 7,000 individuals are appropriately worked up and on the wait list, but die before they have the opportunity to get a transplant. And so one of the overarching principles of the effort to understand donor-derived infections is that we really need to generate this balance between patient safety. If we say that we have to have the perfect organs that have no risk of infections, we'll end up losing organs that are perfectly safe to utilize. Likewise, if we utilize every organ and ignore all of the testing, we'll challenge patient safety. And so we have to fit a balance so that we can optimize the safety and outcomes of our transplantation. And one of the ways that we do that is through testing of the donor. And one of the first cases that really highlighted this is a case of HIV transmission through living donation. The donor was recognized to have engaged in risky behavior. He was a man who has sex with other men. He had a history of syphilis that was previously treated. He had negative testing about 80 days prior to transplant, but no repeat testing close in. The recipient developed oropharyngeal and vaginal candidiasis that was pretty symptomatic early after the transplant. This was blamed on the immunosuppressive therapy. But when the donor went in for his annual HIV test, it came back positive. He told his recipient, who got tested and was positive herself. Unfortunately, looking back on some samples that were available in the HLA lab, they were able to document that the donor was HIV positive prior to the donation, and really highlighted the importance of not only the fact that living donors engage in behaviors that may put them at risk, whether for HIV or even something as simple as West Nile virus. And so we need to think about doing our testing as close into the transplant event as possible, but also to think through when we do have warning signs about problems. As a result of these and other cases, we've transitioned from an era where we relied very heavily on serology to one in which we rely significantly on PCR-based or nucleic acid testing. That's helpful because it shortens the window, but does not completely get rid of the window completely. And we have to recognize that. If a person overdosed with drugs on the day of admission and we do a NAT test 2 days later, they're still within that NAT window period and could have an infection that is not detected even with PCR testing. Initially, there was significant pushback on broad use of PCR-based testing because there was concern that we would throw out organs because of false positive results. What we found is that there were, in fact, cases of patients that were antibody negative, PCR positive. About half of them for HIV were false positive, but there were potentially transmissible cases that were identified. There are also patients that were antibody positive and PCR negative, so false positive testing. More importantly, with hepatitis C, again, we saw a sizable number, almost 200 patients that were antibody negative, NAT negative, and therefore these donors could be safely used in patients without the concern of disease transmission. Through all of this, we recognize that there is some degree of residual risk. The closer you are to the window period of infection, that risk increases significantly, so that you have about a 1 to 3% risk of hepatitis C from a patient that overdoses with IV drugs, and about a 0.1% chance of them having HIV, even if their NAT test is negative. As a result, the OPTN policy was recently updated to require HIV NAT, Hep C NAT, and Hep B NAT, in addition to routine serologies, in addition to CMV, EBV serologies, syphilis testing, and toxoplasmosis testing. All of the recipients also undergo physical examination and review of behavioral and social history. And living donors are required to be screened for TB and other relevant endemic mycoses. The OPTN has also worked very hard to develop clear guidelines for us to use. Most notably, recently, they came out with very useful guidelines to understand the appropriate role of testing and interpretation of those tests for COVID-19 and organ donation. One of the earliest guidelines that were developed was one focused on donors with encephalitis. And what they recognized is that there were certain factors that really should make the providers scratch their heads and think deeply because they may have a form of viral encephalitis that can be transmitted from the donor to the recipient. Particularly cerebrovascular accidents without risk factors, fever at presentation without a clear explanation, CNS imaging abnormalities, or abnormal CSF abnormalities. Likewise, immunosuppressed patients or environmental exposures that may be glanced over could be very relevant to prevent the transmission of disease. Now, one of the things that has happened recently is the classification of increased risk donors has been modified so that we know about it, but we aren't making as big of a production and doing formal informed consent at the time of donation for our patients. And really, I think this is going to help utilization. We can see from these graphs that utilization was increasing over time, but for some, such as the yellow line, which is lung transplantation, this still lagged behind other populations. And when the CDC utilized OPTN data, they found that there was, in fact, underutilization of donors classified as increased risk that varied region to region. There were some regions that were more efficient at using hearts, let's say, or kidneys, where you had a much higher rate of utilization, such as shown in region 9, and then other areas such as region 3, let's say, that has much lower utilization. This also, I think, is an important thing because it also speaks to the fact that this is likely not the patient saying no, but something of a center type effect that may trickle down to utilization by OPOs. And as we've gone to more broader sharing and removing this label, this hopefully will normalize some of these findings as we did when we got rid of HTLV testing. The guidelines have been updated based on emerging evidence, again, thanks to the data that's being collected by DTEC. And so they first looked at all the different criteria that we used to have and identified were there ever transmissions of HIV, hepatitis B, or hepatitis C. And there were several that there just weren't. And so that allowed the CDC to remove several criteria from the list for us to focus on. They also reduced the time frame from a year down to 1 month, in which the risk period was a concern, because with the requirement for NAT testing, really you're somewhere between 1 week of residual risk for HIV and hepatitis C and 3 weeks for hepatitis B. So if you don't have those risk behaviors that are recognized within that 1 month period, the risk of undiagnosed infection goes down very quickly. As an exploratory piece, they have expanded the testing of recipients so that all transplant recipients should get tested for HIV, Hep B, and Hep C somewhere between 4 to 6 weeks after donation. And they changed the current increased risk terminology, which again, I think is more semantics than anything else. To help us better understand the utilization of these organs. Now, we're moving on to how we've expanded the donor pool most clearly is with the use of hepatitis C donors. Unfortunately, with the opioid epidemic, there's been significant increase in the number of drug overdoses, and this has been linked also to an increased risk of Hep C in those patients, and as a result, an increase in availability of Hep C positive donors. In the past, they were down closer to about 1%. Now they make up somewhere between 4 to 5% of the overall donor pool. There are some regional differences, as is shown with these graphs. So again, some areas have higher rates of hepatitis C through overdose than others. There was clear data to show that donors up until about 3 or 4 years ago that were hepatitis C positive were not being utilized in an efficient way. And in fact, the majority of these organs were being discarded. This was in part because of concern about transmitted disease. It was only used in patients with hepatitis C, in part because we didn't have good therapies. Additionally, there weren't significant benefits to the use of these organs, whereas the current data shows that these donors on average tend to be younger and healthier than patients without hepatitis C, about a decade younger than individuals with hepatitis C. So this brings us to another kind of exemplary case. The donor is a 54-year-old female who was previously healthy until she died of a spontaneous subarachnoid hemorrhage. She had hypercholesterol and hypertension, so risk factors. Her testing was negative for HIV, negative for Hep B, but she was HIV antibody positive, NAT negative. So again, a lot of the times in the past before we had the NAT available, these donors just would not have been used. And by knowing that they're NAT negative, antibody positive, we can safely utilize an individual such as this to any patient without special informed consent or concern for disease transmission unless they're an increased risk donor. And this is why we have to just be very careful with our terminology. It's recommended not to say Hep C positive, but to say Hep C viremic donor when their nucleic acid testing is positive. And recognizing that if you test the recipients of these antibody positive NAT negative individuals, they may end up with a positive antibody because of passive transfer of lymphocytes, not because of transmission of infections. There haven't been transmissions of hepatitis C from these donors unless they were also increased risk donors. And that probably is, not because they were antibody positive NAT negative, but because of their increased risk status, acquiring the hepatitis C, since being antibody positive doesn't make you immune and protect you from infection otherwise. Now, it's important to recognize there was this case series that showed a high rate of hepatitis C transmission from the antibody positive NAT negative, but all of the transmitted donors were increased risk donors, as I said. So it's really important to recognize if they're increased risk donor, they still can transmit hepatitis C, even if they're antibody positive. The last area where we've expanded the donation is through the use of HIV positive patients. The HOPE Act allowed for HIV positive donors to be utilized in HIV positive patients. This is expanded greatly for liver and kidney, and it's just starting to be utilized more broadly in the setting of lung and heart transplantation. Over time, we've really grown to understand the safety of these organs and how to optimally manage these patients. Selecting regimens, for example, that don't contain protease inhibitors results in a lower rate of rejection because you don't have as high and low levels of your individual. And also had us realize that treating patients with hepatitis C really will improve the outcomes in these patients, since patients that were Hep C had really worse outcomes if they were HIV positive patients than if they were hepatitis C negative. So hopefully what I've been able to do over this presentation is really highlight on the fact that there's a huge potential to expand the donor pool by understanding the risks of disease transmission. Recognizing that testing can in fact be our friends and improve the availability of organs, and that by collecting this data, and this takes a team effort for all those that recognize the cases, doing the hard work of reporting it and responding to all the questions, really helps us to collect data so that we can best understand which organs can be safely used and which still represent a significant risk. With that, it was a great honor to chat with you, and I'd be happy to answer any questions that you may have.
Thank you, Dr. Ison. Before we go ahead and transition to our open discussion period, I would just like to remind everyone that if you do have any questions, please feel free to go ahead and submit them using the chat feature. Again, that's going to be located at the very bottom of your screen in the Zoom navigation bar. And with that, I'll go ahead and turn it back to Katie to help facilitate some of these questions. Thank you.
Well, I look forward to seeing questions come through after that exceptional presentation, and we'll start with several of those that were submitted in advance. There is, as you are quite aware, and leading several efforts around, a great interest in transmission when it comes to COVID and potential opportunities. A question that was submitted has to do with, you covered the HOPE Act in brief. Could you talk a little bit about that model and whether there's opportunities related to COVID that could be learned from how the HOPE Act was introduced?
Yeah. So I think we have to be incredibly careful about COVID patients. And again, someone just put a chat comment that we have to think about COVID in two ways. Are they COVID recovered, which means they had COVID at some point in the past, they're no longer infected, and they move on, where the priority is not so much understanding, do they have a risk of transmission of COVID-19, but instead, do they have organ quality issues? We know that COVID causes hepatitis, causes cardiomyopathy, causes renal dysfunction, and we will have to do studies to understand if using donors that had severe COVID, for example, have organs that maybe have quality issues that we just have to recognize as a challenge moving forward. I think what the question is getting at is, can we use COVID positive donors into healthy individuals? I think we've learned a lot over the pandemic. Early on, I think all of us remember we couldn't even get the COVID tests on our donors. And so that really resulted in a slowing of transplantation. We then moved to a period of time where anyone that was COVID positive was ruled out for donation. Now I think we're starting to get cases where donors had COVID-19 weeks ago, their test is positive with low viral loads that we can likely safely use. And so I think it's a very different paradigm than HIV, recognizing that COVID can be transmitted potentially with dire consequences. If you look at the case report that Dan Call reported, including the lung transplant recipient that acquired COVID-19, got incredibly sick and almost didn't survive. In the process, infected several team members. So there can be dire consequences with the use of someone that either has inadvertent or unrecognized infection or early infection. That being said, I think we're starting to recognize that donors that are further out from the transplant, even if they have a positive test, can safely be used. I think the bigger challenge is when you get a donor who tests positive, even if their viral load is relatively low, but has no history of COVID-19, or has, for example, gotten the vaccine, we don't quite yet know what to do with those individuals, because that low viral load, high CT value may be someone that's the first day of their infection and during their hospital course builds up more virus and potentially could transmit the disease. Additionally, while we've gotten some positive signals from DTAC at ATC, where outside of the lung there haven't been confirmed transmissions, we do know that certain patients that are very sick with COVID-19 do get virus detectable in the blood. Whether or not that is competent virus that can transmit infection, we still don't know. And so I think if you had someone who was really critically ill with COVID-19 and that was their cause of death, I don't think that's someone that we would be able to safely utilize.
Thank you. There's a question submitted by Karen Lostenow that is I believe related to your sort of proven probable slide where you outlined the level of correlation as you assess infection transmission. So she had questions about that process, I believe, and the sort of distinction between other probable causes of infection versus the donation. So if you could speak a little more about that.
Yeah, so that's really the job of DTAC, and there are, if you want more details, there's both in Dan Call's paper and then I believe it was in 2011 from Mike Green's DTAC paper, a much more detailed description of the exactly flow diagrams and criteria for the who gets classified as what. But basically what DTAC does is, with the help of the OPO, with CDC if they become involved, and with the existing data, we try to understand how much evidence is there that the infection or disease was present in the donor and in the recipient, how many of the recipients, if all 4 recipients had the same disease, even if you couldn't prove it in the donor, where the disease came from. But the criteria really then are applied by the committee to really move it into those classifications. There's one very unique classification, intervention without documented transmission. This is where let's say one recipient has Staph aureus bacteremia, it gets reported, everyone else treats the patient for Staph aureus bacteremia, no one else gets sick, and the testing, let's say the donor cultures were negative. We created this criteria because what you don't know is, did the antibiotic help prevent the transmission in those other recipients, or was there no bacteria there to transmit in the first place? So that way it gave a criteria where we wouldn't be able to really fully understand with the data that we have. So it's really a committee of experts looking at the data, looking at the criteria and kind of plugging it into the right category. And for all practical purposes, we consider proven and probable as true transmitted infections. Proven is where the donor was positive and at least one of the recipients was positive. Probable is when you have 2 or more recipients with the same pathogen and you can't prove it in the donor, but there's plausibility that it came from the donor.
A question that came through the chat from Sue War is about Hep C and how to talk about that in today's terms. So if a person was Hep C positive and received treatment, how should we describe this? Are they considered cured, or do we still refer to them as Hep C positive until serology and NET is resulted?
Yeah. So, if you're talking about their clinical course, and that they were treated, then you could describe them as cured. The reality is the way they should be described is if their antibody is positive and their NAT is negative, that their seropositive NAT negative is the way, or seropositive non-viremic is the best way to describe it. Because if you know that they got treated, the treatment was what rendered them in that way. But we know that about 15% of people that get hepatitis C naturally will clear the infection. So they may never have gotten treated, they may still have cleared the infection. Thankfully, hepatitis C isn't latent in the liver or anywhere else on the body. So once you are cured of hepatitis C, you don't have to worry about it reactivating like hepatitis B, where the DNA gets incorporated into the hepatocytes. And even if there's no DNA in the patient now, if you put that organ into a patient and heavily immunosuppress them, there's always a chance that the virus can reactivate.
I have another question here, but want to make sure you saw the comment from your colleague, I believe, in this work, Kevin Meyer, just complimenting your presentation.
Thanks, Kevin. Yep.
There's a question from Sue Burgett about testing more generally of donors. So she asks about common methods and standards for evaluating potential donors of organs and tissues. And it's a pretty general question, wondering if you could kind of comment a bit on those processes at a high level.
Yeah. So what I will say is we've had a relatively stable testing menu. And despite that, we've seen significant numbers of, for example, strongyloides transmissions through organ transplantation. We've seen some Chagas transmissions through transplantation. And still, from a study that was recently published by Nicole Theodoropoulos, the rate of these optional testing at OPOs is still relatively infrequent. I think that the way that we need to look at potentially bringing new tests into our standard of care is by asking three critical questions. Are there assays that can be applied by the OPOs in basically real time to help us identify the patients ideally FDA approved? And for many of the things that are kind of supplemental testing, there are. The second question is the disease transmissible through transplantation? Because you wouldn't want to test for something that may not actually even cause disease. And then the third question is, how can you utilize that testing? So, for example, there are things like strongyloides where even if the test wasn't available, the result was drawn, but you didn't have the result at the time of allocation, you could still prevent transmission of disease after the fact. You give the recipients ivermectin, that drops their risk to close to zero. So I think in those kind of settings particularly where you can, after the fact, still intervene, I think we really should be pushing forward to that. In other settings where you potentially will discard the organ, so this is one of the challenges with West Nile testing and potentially Chagas testing. These tests may give you some false positives, either because in the case of West Nile virus, the patient was infected but is not at risk of transmitting the disease, or gives you a false positive test, as is the case with Chagas testing. And if you end up throwing away more organs that are safe than preventing transmissions, then perhaps the benefit isn't there. I think in the end, I think this is going to be something that the AST has just started a working group that Stephanie Pouch and I are leading to look at helping to come up with clearer standards for donor screening. I think these are the kind of questions that we're going to be focusing on to try to better understand how can we pick the most common pathogens that we have tests for that we could reliably benefit from screening and implement them. And then I think there's also room for improvement in areas as simple as bacterial infections. Frequently, cultures are done, but they take several days to come back. And that's not only a missed opportunity to treat the patient earlier, but also a challenge in that the patient may have to stay in the hospital an extra day or two if you know that the blood culture is positive for a gram-positive cocci, but it's taking you 3 days to figure out whether it's coagulative staph that you can ignore or Staph aureus that you need to treat.
Wonderful overview. And she did have a follow-up question about whether any testing or any infection-related indicators would affect transport of any gifts, organs, tissues. So that transportation piece.
I think that for the most part, it probably wouldn't. Now, we don't know what's going to happen in the near future. There's a lot of effort to look at cold and warm perfusion of organs. And not only is this an opportunity, perhaps, to intervene on some of these infections, but also an opportunity to improve the organs themselves. And so there's been work that the group at Toronto has done that utilizes these systems to give antibiotics or even Hep C therapeutics to help reduce the risk of transmission with the organs. So I think that there are potential benefits if we move to some of those storage systems. For the most part, transporting organs probably is not going to be an issue, other than, for example, if you know that they have an infection, they may have to be labeled slightly differently, but it wouldn't affect the transport of the organs per se.
Well, I am so excited about all I have personally learned in the last 45 minutes, and I believe that is our time. So I will thank you deeply and turn it back over to Deanna.
Thank you.
Thank you. I certainly just want to echo Katie's sentiments. Thank you so much, Dr. Ison, for all that you've shared today. Truly a fantastic presentation. I can say I've learned quite a bit as well. So thank you for your time today. Thank you for joining us. And Katie, thank you for doing a phenomenal job at facilitating the discussion. We appreciate you always for joining us. So a huge thanks to you both. And of course, to our participants, thank you for joining us today. We hope you found this discussion to be just as valuable, and we look forward to seeing you in the future. Take care, everyone.